So gives me great pleasure today to introduce Professor Manel Lujan, who is a respiratory physician with a background in intensive care at the University Hospital of Parc Taulí in Sabadell, Barcelona. I'm going to let you, Manel, just introduce yourself and tell us a little bit about the centre where you work.
Yes, thank you very much, Michelle. I usually work in respiratory intermediate care unit at the University Hospital of Parc Taulí, but I am also the responsible of the non-invasive ventilation program, chronic non-invasive ventilation program. So I have both skills in the acute care and in chronic care in patients with non-invasive ventilation.
And I can remember about this time last year, or in a month or so's time, we were having a lot of conversation because the COVID pandemic hit. At that time, was there anything that you thought was going really well, considering it was a complete catastrophe? But can you sort of remember back then that anything at all that you found was actually going quite well within your institution?
Yes, my institution, we suffered a first catastrophic wave. The first wave was really catastrophic because we had in 2 weeks we concentrate more than 1,000 patients in my hospital only with COVID-19. So the first wave, we treat the patients in all the wards at the hospital, in the pulmonary ward, outside the pulmonary ward, and was really challenging because we had no enough material, no enough personal protective equipment, not enough positive pressure devices. And during the first wave, one of the most challenging problems was the lack of monitoring of those patients, because we had to face with a lot of patients isolated in individual or double rooms, and we didn't know what was happening inside the rooms. So this was, for me, the main problem, the fear having patients with high flow oxygen or with high FiO2 inside closed rooms. Moreover, these patients usually agitated, were disoriented, agitated during the course of the disease. And we found some patients with the mask weared off and with really in severe situation with a severe respiratory failure. This was for me one of the main problems during the first wave. In the first wave, we usually we treated our patients mainly with CPAP. Okay. Because we didn't have not enough high flow nasal cannula devices. So the second wave, we treated mainly our patients with respiratory failure with high flow nasal therapy.
Okay, so a big switch from CPAP to nasal high flow therapy. Yeah.
Yes, because almost in my knowledge, the literature, the prognosis, the outcome of the patients treated with nasal high flow therapy or CPAP were not very different. I remember the Italian study published in the European Respiratory Journal. And what the main advantage of the high flow nasal therapy is that it's much more comfortable for the patient, because, for example, if we had to ventilate a patient during more than 7 days, it's much more comfortable to do it with high flow nasal therapy than with CPAP. And in the third wave, we are now in the third wave, we have changed it because we are combining treatments. therapy. Well, this third wave, we usually start with high flow nasal therapy. If the patient remains more than 48 hours needing high FiO2, we shift to CPAP therapy.
And are you using ward CPAP therapy, or are you using portable devices?
We are treating the patients with acute care ventilators, for example, with the View 60.
Okay.
Philips, because with the View 60 we have the advantage of Carmen Campos. We have with the View 60 we have the possibility to change therapies. Okay, for example, during the day the patient can be treated with high flow nasal therapy, and during the night we change easily to CPAP therapy. Yeah, this is the first point. The second point is if the patient is not responding to CPAP therapy, we make daily assessment with ultrasonograph to assess the distribution of the opacities of the lesions. If the opacities are mainly at posterior, we try to prone the patient with CPAP therapy for about 3 or 4 hours during the morning. So we change the modalities of non-invasive support, combining high flow nasal therapy, CPAP therapy, and if the CT scan or ultrasonography demonstrates us that the asymmetry in the lesions, we try to prone the patient while awake with giving drugs like morphine or similar.
Yeah, I think that's certainly been happening in the UK, encouraging with non-invasive aid self-proning patients. So they're doing it themselves for prolonged periods of time. And your patients, are they using self-proning mainly when they've got high flow therapy? I'm just thinking about proning and having a interface can be a bit of a problem. So
Yes, we use the patients. If the patient is it's enough collaborative, we trying to sell that the patient self-prones. And with it's important, in my opinion, it's important to combine the prone with the CPAP, because with the CPAP we try to recruit the dependent zones of the lung, and it's really difficult in some patients. But for example, we use full face masks, and if with full face masks, the patient can be proned and with the head so at one side, and the patient, my experience, the patient tolerate reasonably well the prone position with CPAP therapy.
I think we've also been finding that patients have almost been starting to do it before you want them to, because they've learned that they feel better, that they can breathe better, and they sort of know that it's about time that they need to.
Yeah, it's really it's a key point to explain clearly the patient what is his or her clinical situation, and to explain him or her the benefits of a prone position. Yeah. It's absolutely basic to explain clearly to the patients, because it's better with a collaborative patient. If the patient is unable to understand this, the things become really difficult.
And you've given me some beautiful information about the patients that you'd use high flow with and CPAP. Is there a specific group that you would prefer to use bi-level support with?
Yeah, we restrict bi-level support if the we usually the non-invasive support based on estimated tidal volume. Okay. For example, if we have a patient who is treated with CPAP, Well, we measure or we look at the screen of the View 60 and we assess we look at the tidal volume. If the tidal volume is very high, we treat to give low doses of morphine sulfate, trying to decrease the respiratory center output. If the tidal volume is lower, for example, less than 6 ml per kilo, we change and we treat it with non-invasive ventilation, with BPAP mode. Another condition in which we treat with B level is in patients with neuromuscular disease or COPD or underlying chronic respiratory disease. But if more or less we treat 90% CPAP and 10% with bi-level.
And you sort of mentioned neuromuscular and COPD. I mean, what we found in the first wave was our home mechanical ventilation patients were all shielding. They were very well protective. Minimum patients actually even contracted the virus, let alone were hospitalized. However, we're seeing different things this time round, and it may be that because the UK has a particularly transmissible variant at the moment, no matter how well you are shielding, just by default that it's so much more transmissible, we've found that our home mechanical ventilation cohort have been admitted to hospital. There have been patients that have been at home absolutely fine, but have been positive, and those that have been a little bit dodgy. So it's interesting that this time around we are seeing something different. I don't know whether you're experiencing that in Spain as well.
No. In Spain is different, yes, because, for example, the cohort of our COPD patients contracted the disease, but they didn't present severe illness.
Yeah.
And the same for neuromuscular patients. We had some neuromuscular patients infected, but they didn't develop serious illness. I don't know what will happen in the coming weeks or months, because the British strain it's coming now. Yes, it's coming now, and this is interesting information that you had problems with neuromuscular or COPD. At this time, we had no problems with this kind of patient. My feeling is that the COPD and neuromuscular patients presented less severe disease.
Yeah, it was those that couldn't shield. So, for example, they needed to have carers within the home. They couldn't just rely on one person like in the first wave. And I think, unfortunately, just this time it managed to get into people's homes, whereas last time it wasn't as transmissible and it was easier. You sort of thought, wow, this isn't going to last for long. We can sort of batten down and cope, but you can only care as much as you can without help for so long before cracks appear. So yeah. But it is amazing that, as you said, that some of the patients it doesn't hardly affect them at all. They just know that they've had it because they've had a positive swab or they've been slightly unwell.
Yes, we had some very, very severe patients with high dependency of non-invasive ventilation who became positive, but with really few symptoms. This is our experience, and the majority of our COPD patients didn't infect.
I think we're getting better prepared every single time we get a wave. Is there, obviously, medical treatment and management has come on. We've got some drugs in the bag. We're utilizing sedation more with these patients, which we wouldn't normally massively do with non-invasive aids. Is there anything you think we're missing, or any devices that you think need to be developed to manage the COVID patient, or do you think that we've got our toolbox and we've got enough there?
I believe that the most useful combination of therapies has been the possibility to switch rapidly from high flow nasal therapy to positive pressure therapy.
Within the same device?
In the same device. In the same device and with the same limb or humidifier. Yes, this has been, for me, the main advantage of this third wave, the possibility to rapidly change the modality of non-invasive respiratory support.
That's lovely. I'm going to say thank you very much. I know that you're very busy today, so thank you for taking the time out to talk to me about COVID and how you're coping. And that's some key gems that all of the viewers to this can take away. Thank you.
Thank you, Michelle.